always takes some getting used to speaking to a mostly empty room, but thank you for everybody who came in person. I was just talking to my mentor, Dr. Blockett here, and we are saying that we should reinstate lunch or something, and there would be at least some sort of a draw to kind of get together. But hello to everybody who's there on Zoom as well. I have a number of slides prepared, and so I think I'm just so that we can try and get through the presentation, I'd appreciate if people could save any questions or comments till the end. But of course, if there's anything burning or if there's something that needs to be clarified, just jump in and let me know. For those of you I haven't met before, I'm Sarah Hansen. I'm an adult rheumatologist affiliated with St. Paul's and the UBC Division of Rheumatology. After I qualified in 2022, I spent a year down at the National Institutes of Health in the States, working with a lab, Dr. Dan Kastner's lab, who are studying genetic causes of autoinflammatory disease. And then since coming back and starting my practice here in Vancouver, I've been seeing patients for autoinflammatory disease consultation as well as general rheumatology. So I was hoping to speak to you guys today a little bit just about the kind of autoinflammatory landscape, because I think it is a rather new and rapidly evolving field that many people, including rheumatologists, may not be entirely familiar with or comfortable with. And I hope at the end of the presentation today, not that anybody's going to necessarily be an autoinflammatory expert, I'm still working on that, but just that you might have sort of a higher index of suspicion to think of some of these cases in patients or families that you might be seeing, and to consider referring on for consideration of genetic testing or additional workup. So my disclosures, I have accepted consulting fees from SOBI and I have honoraria from Vancouver Island Rheumatology Association. I will be discussing off-label treatments during this presentation. Obviously in the rare disease space, it's mostly going to be off-label treatments, but in doing so, I will attempt to use generic names of products, discuss available treatment options and data supporting efficacy, as well as making recommendations in concordance with expert opinion. And then I'd also like to just briefly pause for a land acknowledgement and begin by acknowledging that the land on which we're gathered is the unceded territory of the Coast Salish peoples, including the territories of the Musqueam, Squamish, and Tsleil-Waututh nations. So the learning objectives, I believe they may have been circulated, but I was delinquent sending at them ahead of time. I'm hoping that by the end of today, we'll be able to appreciate the expanding spectrum of clinical manifestations associated with autoinflammatory disorders and situate those manifestations within a contemporary pathway-based management scheme to describe key features of some of the more recently described monogenic autoinflammatory disorders, including DADA2, COPA syndrome, and haploinsufficiency of A20. And then finally, to discuss advances in pathway-based management strategies for autoinflammatory disease. And just a brief overview of the talk. So we'll begin by just discussing what I consider to be the evolving definition of autoinflammatory disease, when one should think about suspecting an autoinflammatory disease, a little note about autoinflammatory diseases in adults, and then finally some discussion about these sort of contemporary pathway-based classification schemes and the implications for pathway-based management. So let's start by talking about the evolving definition of autoinflammatory disease. And I'd like to title this session, What is an autoinflammatory disease and why should I care? Because a lot of people don't really know what an autoinflammatory disease is. So show of hands here or online, who has heard of autoinflammatory disease before? Can anybody name an autoinflammatory disease? Are any of these conditions up on the screen familiar to you? Maybe people have heard of familial Mediterranean fever at least, right? Yes. So that's the most common monogenic autoinflammatory disease. And it had long been recognized, particularly sort of in the Mediterranean basin, that there was kindred, so multi-generational families that had sort of recurring, sort of stereotyped episodes of inflammation, fever, peritonitis, arthritis, rash, and that these patients had been quite sick and sometimes dying early in life of systemic AA amyloidosis. But up until Dr. Kastner's team localized the gene for FMF, the MEFB gene, in 1997, after basically like a 10-year project of trying to sort of find this gene, we didn't know what the genetic cause was. And then soon after that, the same lab found the gene for TRAPS, and then the gene for HIDS, or mevalonate kinase deficiency, was discovered, Muckle-Wells syndrome, Blau syndrome, and sort of about 20 years ago is when this field that we call autoinflammatory diseases was sort of coined and was born. And so at that point in time, and I think up until pretty recently, how we've all sort of thought about autoinflammatory diseases is, a group of mainly monogenic disorders, so caused by a gene that's present in the germline, gene mutation present in the germline, resulting in spontaneous activation of the innate immune system, so the myeloid compartment, not the lymphoid compartment. Recurrent attacks of unprovoked inflammation, so i.e. irrespective of infection or malignancy, a lack of high titer autoantibodies, lack of autoreactive T cells, and in most cases, onset in childhood or early in life, as you would expect with a monogenic disease. And so the key features, this is a little bit repetitive here, but you might think to suspect, familial Mediterranean fever in somebody who has, recurrent episodes of fever lasting 1 to 3 days associated with peritonitis, board-like rigidity, disabling abdominal pain, or, inflammatory arthritis that kind of pops on and off within the span of a couple of days, a little bit too short for gout, but definitely sort of reminiscent of that same sort of flavor. Symptoms across multiple organ systems, patients with early onset or familial disease. And so this is a schematic here, just showing you sort of the approximate cost of whole genome sequencing. And so you can appreciate that, at the end of the Human Genome Project, which was concluded in the early 2000s, the cost of that project was $3 billion US dollars. And then in 2004, that's when the advent of next generation sequencing came along, this massively sort of parallel sequencing. And I remember being at early in my undergrad, sort of when these competitions were going on and it being sort of like this very exciting time for genetics. And then since then, sort of like this exponential sort of fall in the cost of genome or exome sequencing, such that currently in 2024, it's quite easy to order, an exome for $1,000 on sort of like a clinical basis, or, a very large targeted gene panel for a couple of hundred US dollars, and to get those results back very quickly. And as a clinician, it's possible to do that. It just takes a little bit of paperwork to fill out, or you can refer to somebody who has the know-how in terms of being able to do that. And so with the falling cost and sort of the increasing availability of genetic testing, what happened was that there was this rapid expansion of sort of discovery. And since sort of the gene for FMF was discovered in the late 1990s, there's been over 50 different monogenic autoinflammatory diseases that have been discovered, including more than 10 in the last 5 years. And so I think that, what I'm going to try and convince you over the course of the next, 40 minutes or so is that, compared to these sort of like diseases that were discovered earlier on, a lot of the sort of more newly discovered diseases have features that one wouldn't necessarily think of being as classic for autoinflammatory disease, and that there's more and more sort of like a blurring of the sort of boundaries in terms of the phenotype, with many of these patients presenting with clinical features that may be reminiscent of autoimmune disease, sometimes positive autoimmune serologies or autoantibodies, sometimes autoreactive T cells, and that really I think we need to be having sort of a higher degree of clinical suspicion for some of these disorders in patients that we may be encountering in the ID clinic, in the heme clinic, on the general internal medicine wards, particularly if there is sort of a pedigree or family history that's sort of suggestive of some pattern of sort of like genetic predisposition. And so some of the, I guess, like clinical features or phenotypic manifestations, which might lead one to consider a diagnosis of autoinflammatory disease, I think need to be expanded to include patients with early onset stroke, as in the case of DADA2, or polyarteritis nodosa-like disease, again, a feature of DADA2, CVID. So I think as an internal medicine resident and even as a rheumatology fellow, I always considered CVID to be a disease, right? But it's actually not. It's a phenotype. And there's many different sort of monogenic etiologies of CVID. And so really in a patient that's presenting with a CVID phenotype, particularly if the phenotype is a little bit more interesting, a little bit more inflammatory, those patients should be definitely everybody having genetic testing. There's diseases that may present like Behçet's disease. So diseases including the haploinsufficiency of A20 or REL-A haploinsufficiency that may present similar to lupus, that may present with autoimmune hepatitis. And these disorders are often disorders that are affecting sort of the REL pathway, the NF-kappa B pathway. And then there's patients that may have more of sort of like, they may look more like a traditional lupus patient or dermatomyositis patient, where they may may have interstitial lung disease, inflammatory arthritis, Raynaud's phenomenon. And these are oftentimes patients that are affected by a gene mutation that's involved in the interferon, the type 1 interferon pathway. So just a couple slides now about the immunologic disease continuum and just trying to sort of situate our discussion today in terms of an understanding of Mendelian versus complex genetic disease. And so this is a schematic that's been sort of adapted many times. I believe it was first sort of published by Dennis McGonigal's group in the UK, kind of like 10 years ago or so. But basically just speaking to the fact that the immune system is complex, nothing exists in isolation, and that there's a continuum starting from the left of the screen for these sort of monogenic, sort of more pure autoinflammatory disorders like familial Mediterranean fever, Muckle-Wells syndrome, COPA syndrome, some of which may actually appear more autoimmune in terms of their phenotype, to on the far right side of the diagram, monogenic autoimmune disorders, and then kind of this meeting in the middle, recognizing that most patients, with lupus that you might encounter in the clinic are going to have sort of a polygenic risk score for their lupus, and then some contribution of environmental factors, other elements in the genome. Same thing with these complex autoinflammatory disorders, where you might have a patient with recurrent fevers, recurrent sort of episodes of arthritis, mouth ulcers. You do the targeted gene panel, it comes back negative. So that patient may have an undifferentiated autoinflammatory disease, which is likely something genetically complex that we're not able to detect on one of these targeted gene panels. And then finally, these disorders that we would consider to be kind of like at the sort of intersection of innate and adaptive immunity that we would consider to be mixed pattern disorders. Now, this is a slide that I adapted from Dan Kastner. And does anybody want to hazard a guess what disease this diagram is speaking to in terms of the genetics? So this is Behçet's disease, and the giveaway should be HLA-B51 in the middle here. And basically this schematic, I think, is very instructive, very illustrative. On the y-axis, just thinking about the effect size of a gene mutation. So, a monogenic mutation with a large effect size, but that at the same time is very rare, like mutations in the gene TNF-AIP3, which is the cause of haploinsufficiency of A20. These patients may present with a phenotype that's almost identical to Behçet's disease, with oral genital ulcers, arthritis, erythema nodosum, uveitis, but it's actually caused by a genetic mutation in this gene here. Whereas, as you move sort of more towards the right of the diagram, the bottom of the diagram, these are sort of the susceptibility loci, these genes here, that might be sort of detected in a genome-wide association study as being more common in patients with idiopathic Behçet's disease compared to age, sex, and ethnicity matched controls. And so really, when we're talking about sort of autoinflammatory disease, it is important to consider that, there are these very sort of rare monogenic conditions that have a high sort of phenotypic impact, but the majority of patients presenting with an autoinflammatory phenotype are going to be having more genetically complex disease. And then this is a similar schematic to the last couple, just speaking to the fact that in addition to the burden of sort of like rare versus common genetic sort of variants, innate versus adaptive, there's also interplay with the environment and sort of environmental triggers, infections, et cetera. So a couple of slides now, just trying to convince you why we should be thinking maybe a little bit more about autoinflammatory diseases in adults. Certainly, monogenic disorders are more likely to present in the pediatric population, but they can certainly present in the adult population as well. This study is a little bit old right now. It's about 10 years old, came out of the Cleveland Clinic. And basically they sequenced with a targeted gene panel 266 adult patients presenting with a clinical phenotype that was suspicious for a systemic autoinflammatory disease. And they actually had close to a 30% hit rate. Now, I think that this statistic is a little bit inflated because more than half of those patients were labeled with this disease that we call NOD2 autoinflammatory disease, which is a little bit of sort of like a questionable sort of entity in the literature right now. It may be sort of more of a complex autoinflammatory condition, or it may be just something that's kind of like bad science completely made up. But even if you discount those, out of 266 adult patients that were sequenced, they found 13 with FMF, 6 with TRAPS, 5 with Muckle-Wells syndrome, and 1 with HIDS. And so that's still a pretty good yield, right, in terms of sequencing those patients that had like a pretty convincing phenotype. And so why might autoinflammatory diseases present in adulthood? So I kind of divide this up into kind of two clusters. So there's patients who may have had symptoms that started in childhood, but even though they were presenting to care, hospitalized for long periods of time in childhood, there was either a lack of case recognition on the part of the providers, or maybe their sort of disease just wasn't discovered yet. Some patients may have had like a milder phenotype and not have presented until adulthood, potentially with the birth of like an affected child, which then sort of led to this aha moment of, oh, there must be something really going on here, that there's this sort of, multi-generational sort of pedigree with fevers or autoinflammatory manifestations. Or some patients may have been worked up at research centers of expertise around the world for what was considered to be an autoinflammatory phenotype, but potentially their sort of disease just hadn't been discovered yet, right? And so there's, vast sort of databases of genetic sort of data that's waiting to be sort of, put together in terms of, 3 people with a similar phenotype in the same genotype so that we can sort of discover a new disease. And then the second group is patients who might have disease that actually starts in adulthood, and that can happen for a number of different reasons. So autosomal dominant conditions in particular, there's this phenomenon of what we call reduced clinical penetrance. And so that means that even within the same family, within the same kindred, who may harbor exactly the same genetic mutation, some people may have a very strong phenotype, others may have a milder phenotype that starts later in life, some may actually be asymptomatic. We don't have a great understanding for exactly why this happens, but it's probably to do with sort of interplay between that sort of strong monogenic variant, other elements in the genome, or potentially sort of environmental factors that they've encountered throughout the lifespan. There's patients who may not present with an autoinflammatory phenotype until adulthood because they have a genetically complex disease. So lots of little sort of low impact mutations interacting with environmental triggers. There's patients who may have somatic variants. And then there's something that sort of is recently being sort of like more and more published on called clonal hematopoiesis, which overlaps more with sort of like the hematologic, the myelodysplastic syndrome space, where really we're talking about somatic mutations that start later in life as opposed to earlier in life. So a slide here about germline versus somatic variants. So, we're all, the product of sperm, egg, right, comes together. If there's a mutation from mom or a mutation from dad that we inherit, it's then going to be present in all of the cells in the body. Sometimes also a germline variant can happen de novo. So sort of like, so it's not inherited from mom or dad. It just happens de novo, particularly in that gamete. And then there's on the right side of the diagram here, there's what we call somatic variants. And this is what's going to sort of give you more of that mosaic genetic or genotype, where it's only a certain percentage of the cells in the body that are affected. And this is because the mutation happens either early in the post-zygotic phase or later in life. And, what we're appreciating more and more is that, we're all sort of making these little mutations throughout our lifespan, right? Even in a healthy 20-year-old person, if you biopsy the esophageal mucosa, you can see that there's already multiple sort of somatic variants or mutations that have accrued there, most of which have no consequence for us, but these sort of like unlucky sort of somatic mutations that are basically errors of DNA replication get acquired throughout by cells throughout life. And then most are inconsequential, but some of them will lead to either sort of like an inflammatory, pro-inflammatory phenotype, or lead to clonal sort of expansion of hematopoietic cells. And that's what's sort of the driver for like myelodysplastic syndromes, for cancers, and also contributes to some of the inflammatory burden that's associated with cardiovascular disease, for example. And so these clonal sort of mutations, these somatic mutations, I think like probably a disease that most of us in the internal medicine space are familiar with is the VEXAS syndrome, right? So the VEXAS syndrome is an obligate somatic mutation in the gene UBA1, which happens sort of like, either early in the post-zygotic phase or later in life. It's only affecting a certain percentage of cells in the body. And then we think that it sort of manifests later in life in these mostly older men because of this sort of like clonal hematopoiesis, where there may be a second driver mutation causing those UBA1 mutant clone to sort of expand. And then this is a nice sort of mock-up I won't spend too much time on it, from a really nice article in New England Journal of Medicine last year, just sort of discussing sort of the role of somatic variants in a lot of different diseases. It just sort of speaking to the fact that, you can either have gain of function in effector immune cells, or potentially sort of the mutation resulting in neoantigens. And so sort of like inflammation that's being sort of produced in response to those mutant neoantigens with an otherwise sort of normal immunologic compartment. This is the last slide that last couple of slides that I'll have on this subject, but just speaking to the fact that, I think we've all heard of the VEXAS syndrome, right? Like older men who have like cytopenias, chondritis, recurring pneumonias, inflammatory lung disease. We probably need to be transplanting more of these men than we are doing currently, but that's sort of like still in the works in terms of clinical trials and whatnot. But we also recognize that just in patients with myelodysplastic syndrome in general, that, a significant proportion of them do have an autoinflammatory phenotype. So fevers, rashes, arthralgias, pleurisy, elevated CRP, and some may actually meet criteria for an autoinflammatory disease. And so Dr. David Beck, who's the person who discovered the VEXAS syndrome, is currently very sort of interested in sort of sequencing, sort of deep sequencing for these sort of somatic variants, which may sort of underlie the autoinflammatory phenotype associated with some of these diseases. And then I'll skip over this, but just to say that there's this one sort of particular type of myelodysplastic syndrome that's driven by trisomy 8, and that this basically type of MDS can present with a phenotype that's basically identical to Behçet's disease, with sort of bipolar ulcers, inflammatory arthritis, et cetera. And so really just sort of like, I think, pretty compelling evidence that these sort of clonal hematopoiesis mutations are sort of driving an inflammatory phenotype in a lot of our sort of older onset autoinflammatory patients. All right, so now with that sort of long introduction, we're kind of getting into more of this kind of pathway-based disease classification scheme, which is really, I'm going to hope to convince you, with our, improving understanding of innate immune cell biology, we've then be able to sort of classify these sort of 50 or so different sort of monogenic disorders, more from like a gene-based classification system to more of like a pathway-based classification system that's sort of basically just showing us how, variants or mutations in multiple genes along the same pathway can actually produce a phenotype that's similar in terms of the clinical manifestations. And, I think that, what a lot of sort of autoinflammatory sort of experts and labs and groups around the world are doing is that increasingly they're being smart instead of just reaching for, interleukin-1 inhibition to treat people with recurrent fevers. We kind of want to look a little bit more at sort of like what the clinical manifestations or the phenotype might be, and try to sort of, even if the genetics are negative, think about sort of what's more likely in terms of what pathway we should be targeting and how we can effectively do that with targeted therapies. And so I'm going to be speaking a little bit to these sort of like 5 innate immune sort of intracellular pathways. First, the inflammasomopathies, actinopathies, protein misfolding cellular stress, NF-kappa B, cell death, and the interferonopathies. So we're not going to have time to discuss all of these diseases, but this is basically just a cartoon to show that there is inside of all of our sort of innate immune cells, the myeloid cells, there's this basically this macromolecular complex which can polymerize very rapidly out of preformed elements in response to upstream stress triggers. And so the sensor molecules, NLRP3, that's associated with the Muckle-Wells syndrome, pyrin, obviously associated with familial Mediterranean fever, and that in response to certain upstream sort of stress signals, this inflammasome complex can polymerize very rapidly to catalyze the production of interleukin-1 beta, which is then released from the cells in sort of like this fiery form of cell death called pyroptosis, where basically there's, a disruption of the osmotic gradient by the formation of this sort of Gasdermin D pore, egress of interleukin-1 beta, egress of,
I'm listening to something. Sorry. Go ahead.
Egress of interleukin-18, and then osmotic swelling and cell death that's associated with that. And so there's a number of different diseases that have been associated with these inflammasomopathies. Just ask everybody to mute their mics, please.
So this patient was cut over for cycle 25.
I'm just going to keep going.
They've got an issue with
Oh,
the
thank you.
dosing for 24.
Okay, sounds good.
Which is
So
to
basically, the
because
inflammasomopathies, for the most
seem to
part,
be a
are going to
lead or
be
whatever.
responsive to
So
interleukin-1
when I looked at the
inhibition with
dose that I've
medicines
seen, I
like
figured it must be
anakinra,
in
canakinumab,
24. So
rilonacept.
I went
But some
back
of
to
them, like
that
the
that
NLRC4
the
inflammasome in particular,
24. I
they
was
seem
like,
to
no,
be
no, it's
associated with a little
24
bit more
milligrams, right?
IL-18
It's
production.
25
Those can be a little bit
milligrams.
trickier to
So I
treat.
renamed
There are
25 to
IL-18
24.
sort of targeted therapies
Right?
that
This
are
is the
in
first time
development,
somebody
not
doing that.
currently available in
So I renamed
Canada,
this 24.
unfortunately, but we'll
I
sort of
changed
hope
the
for those to
prescription
come
to another
eventually.
50.
I'm going to skip over this for the
And
sake
then
of time, but it's a
scheduling.
cool video on the inflammasome. If you guys want to
So
see
you
it
want to
later,
change the
just ask
scheduling,
me.
right? Because you wanted in
And
3
so
weeks
this is
now.
just
Well, scheduling is
really
already
briefly to
confused.
touch about the
Yeah, but that's in case, not in
inflammasomopathies
Cerner,
that,
unless it's in
even
appointments.
in people
Is it in
who
appointments?
have the same
Well,
sort of
so
like gene that's affected, there's like a vast sort of spectrum of clinical
Yep, it's in there.
manifestations
yeah, so
that can result in
So
sort
you
of
can take
different
out the scheduling
diseases that are
part.
caused
this
by
is gonna say
mutations within the
change
same gene.
So you
And
can just
so
take that part
this
out.
is an
Just
example of
continue.
CAPS or cryopyrin-associated periodic fever syndrome, with Muckle-Wells sort of being the most common sort of mid-severe phenotype. And the estimated prevalence is about 3 to 5 per million. And currently, I'm actually following quite a large family in my practice that was sort of worked up by Dr. Sheldon and Dr. Lehman, who all had
Pharmacy
sort
should
of,
see that.
relatively early onset sensory neural hearing loss, who maybe had some inflammatory arthritis, but they did not have fevers and they did not have rash. And I think for that reason, nobody really
But did
put two
somebody
and two
approach you to
together.
change
And
their dose?
unfortunately, these people have developed severe
So do
sensory
that
neural
and then
hearing
just
loss. And so it's
message
just
Center
to
Pharmacy
say
and
that,
say PPO has been
even
updated or
patients with
something.
these inflammasomopathies, where one would think like interleukin-1 acts on the hypothalamus, it produces fever, this is supposed to be a hallmark feature of these diseases, that they may not have fever in a sort of fairly significant proportion of cases. And that really, if you do see sort of people with early onset sensory neural hearing loss or pedigrees where this is like a strong feature of the family history, that we really need to be sort of considering this disease. And this basically just speaks to the fact that patients with Muckle-Wells who are diagnosed
I'm talking about the one
over sort of the age of 20, they tend to have more organ damage, more fatigue, less of these sort of recurrent fevers, recurrent rash. And so again, just to speak to the fact that even amongst these sort of inflammasomopathies, where it seems like we should be able to identify them on the basis of these, strong, high recurrent fevers, these neutrophilic urticarial rashes, whatever the case may be, that is not always maybe quite so straightforward. And then in terms of pathway-based management, I've already spoken to the fact that, really that sort of inflammasome pathway tells us that we can target interleukin-1, we can target interleukin-18, and that really in patients who are sort of like presenting with these really sort of classic clinical manifestations of an inflammasomopathy, that we should be thinking about reaching for sort of these therapies off the shelf, even if the genetic testing is maybe negative, because as on this slide here, there's a significant proportion of patients with CAPS or Muckle-Wells syndrome that have a somatic variant that may not be picked up because it's only affecting like a certain percentage of cells. It may get lost in sort of the noise of sequencing, and it may be that deep sequencing with sort of like higher depth of coverage is needed to sort of uncover that mutation. And so in somebody with a characteristic clinical phenotype, fever, neutrophilic urticaria, hearing loss, even if the genetics is negative, you still need to be sort of thinking about treating that patient for Muckle-Wells syndrome. So the next category here, I'm not going to spend too much time discussing right now, but basically this is just to speak to the fact that actin, right, is one of the components of the cytoskeleton. And what we're sort of increasingly appreciating is that sort of the subcellular location of proteins and sort of is very important to sort of their functioning. And then also, the actin cytoskeleton being essential in terms of cell polarity, migration, et cetera. And so there's a number of disorders which were previously sort of classified otherwise that we're recognizing are actually related to these sort of immune-related actinopathies, including the DOC11 deficiency, which was published last year in Blood and in NEJM, where patients are maybe having like more of a sort of an X-linked, so young men with an autoimmune phenotype that's as a result of DOC11 deficiency, which is resulting in this sort of immune-related actinopathy. actinopathy profile. And so patients with actinopathies, there's a wide sort of spectrum of clinical manifestations, but they may often have fever, but not sort of like these discrete fever episodes. It may be more chronic or more protracted. They may have dyshematopoiesis, cytopenias, immunodeficiency, autoimmunity, oftentimes enterocolitis, and that oftentimes, interleukin 1, interleukin 18 are at play, but other cytokines as well. And that really sort of, these are difficult diseases to treat. In some patients, we may be looking at sort of pushing them to bone marrow transplant, but that there's sort of like a wider spectrum of treatments that may be necessary in order to control the inflammation for these patients. I wanted to spend a little bit more time on NF-kappa B and cell death. And so this is, I think we've all heard of NF-kappa B. I hope so. It's a very important transcription factor. It's the transcription factor that's kind of like targeted by prednisone, for example. And basically downstream of the TNF receptor complex, there's sort of this intracellular signaling cascade, which then leads sort of the NF-kappa B transcription factor to enter into the nucleus and sort of promote the transcription of pro-inflammatory cytokines, including TNF, interleukin 6, et cetera, which then can exit the cell and then sort of signal back in sort of like this vicious cycle of positive feedback. And then sort of also in this family of rhelopathies, there's a sort of acknowledgement that sort of in conjunction with this sort of like NF-kappa B sort of signaling pathway, that at a certain point that needs to turn off. And so patients will get sort of shunted towards more of a cell death pathway by this molecule RIP kinase 1. And that sort of basically patients who get then more shunted towards inappropriate sort of activation of cell death, particularly necroptosis, which is more of a pro-inflammatory form of cell death, is that they can have a lot of sort of inflammatory manifestations that may actually mimic like Behçet's disease. For example, in the case of haploinsufficiency of A20, may mimic juvenile idiopathic arthritis. In the case of Blau syndrome, patients with uveitis, arthritis, rash. Patients with sort of a hereditary form of blindness, as in the case of the Rosa syndrome, which is affecting the ALPK1 sensor of bacterial 5-carbon sugars, such that sort of like gain of function mutations lead to sort of constitutive activation of this NF-kappa B pathway. And then the Crea syndrome, which basically involves this RIPK1 protein that can't be cleaved to its inactive form. And these are patients that tend to present with sort of like early onset fevers, abdominal pain, lymphadenopathy. And these patients actually respond quite well to interleukin 6 inhibition with tocilizumab, for example. And so really the rhelopathies, these diseases that I've just talked to you about, really sort of, I want you to think about these diseases in patients who may be presenting with Behçet's-like disease, particularly if their disease started early in life, or if there's sort of like a familial Behçet's sort of phenotype or pedigree going on. Patients with a JIA type phenotype that's maybe sort of like more sort of inflammatory than one might expect. And really sort of for this pathway, a lot of times we can get away with sort of TNF inhibition, interleukin 6 inhibition, and sometimes colchicine can be helpful as well. And then the last intracellular pathway that I wanted to talk to you guys about was the interferonopathies. So basically this pathway is involved in sort of like the innate viral sensing machinery, where basically these are sensors of intracellular nucleic acids or cytoplasmic nucleic acids, pardon me. So usually our nucleic acid is packaged neatly in the nucleus, but if they find nucleic acids in the cytoplasm, that's a danger signal. It could be as a result of a viral infection. And so, gain of function mutations in sensors of nucleic, sort of cytoplasmic nucleic acids can result in constitutive activation of this interferon pathway, where basically the final common pathway is that you're getting transcription of type 1 interferon that's then exiting the cell and then signaling via the interferon alpha receptor, and then downstream of that JAK-STAT signaling, then translocating to the nucleus again, and then acting as a promoter on this interferon stimulated response element, and then the transcription of what we call these interferon stimulated genes. And we can actually send out to commercial labs in the States, for example, for an interferon stimulated gene signature, relatively inexpensive, less than $100 US. And so some of these patients, they may not have a classic CRP elevation. They may look more like a lupus patient where they're very inflamed, but it's not a CRP driven process. It's an interferon interferon-driven process. And so they're not necessarily going to have a strong CRP response, but we can detect the inflammation in the form of this interferon-stimulated gene signature. And as you can probably appreciate, we could think about maybe using JAK inhibitors to target this pathway. We could think about maybe using, anifrolumab, which is a blocker of the interferon A receptor, to sort of target these in more of a thoughtful manner, as opposed to just like resorting to prednisone, for example. All right, and so the hallmark features of these interferonopathies that I want you guys to think about is a patient who's maybe presenting with sort of like inflammatory manifestations, but who may not have fever or CRP elevation, who may have a lot of vasculopathy, so Raynaud's, gangrene, livedo reticularis or livedo racemosa, interstitial lung disease. Oftentimes they'll have basal ganglia calcification in the CNS, and a lot of them may have high titer autoantibodies as well, which is an interesting feature of some of these diseases. Okay, so for the last 20 minutes or so, I just wanted to kind of blast through some of these more newly discovered monogenic autoinflammatory diseases, just to sort of illustrate some of these concepts that we've been talking about for the last little bit. So the first is, it's not really new, but it's relatively new. So DATA2, initially published in 2014, and to date, over 600 patients have been reported in the literature, but it's probably vastly underdiagnosed, as I'll attempt to prove to you in a couple of slides here. And it was initially described as like a monogenic form of systemic vasculitis that looks a lot like polyarteritis nodosa, and can also be a cause of early onset strokes in children or young adults. And the important thing about this is that, compared to PAN, which we treat with cyclophosphamide, these patients actually need TNF inhibition, because cyclophosphamide and prednisone, they might feel better, but it doesn't actually prevent the stroke. So we need to be recognizing patients with DATA2 so that we can get them on effective stroke preventing therapy. And this is just to speak to the fact that, we used to think that ADA2 deficiency was resulting in sort of like a polarization towards more pro-inflammatory M1 macrophages, increased propensity to netosis, and that was sort of the main mechanism of inflammation. But what's been sort of recently sort of discussed at conferences, a lot of sort of unpublished data that labs are trying to get out, is that actually, patients with DATA2 also have upregulated interferon signatures, which makes sense in terms of some of the clinical manifestations that we're seeing, and that actually like ADA2 sort of may be sort of like a sink for sort of endogenous sort of reoviral elements in the genome that are sort of being reactivated, and that ADA2 sort of may actually be a sink for those. And so then we're deficient in ADA2. Basically, there's more sort of like cytoplasmic sort of viral or sort of reoviral elements that are around to sort of signal via this interferon pathway. And so this is just showing here that patients with DATA2, they tend to get a lot of sort of deep brain, sort of lacunar type strokes, which can be ischemic secondary vasculopathy. They also have vessel wall fragility, so they can get more hemorrhagic type strokes. They can have livedo reticularis, gangrene, immunodeficiency sort of being a feature as well, where patients often have sort of very sort of refractory sort of warts as a manifestation. And then this is basically a slide just summarizing here that we're probably, like I said, vastly under-recognizing and under-diagnosing this condition. Pio Lee's group out of Boston did a really nice analysis where they basically looked in like large population databases to see what was the carrier frequency for ADA2 variants that were predicted to be pathogenic according to sort of like residual enzyme activity cutoff scores. And what they found is that in those sort of large population databases, like the NOMAD database that has like hundreds of thousands of sort of genomes of sort of healthy individuals in the general population, that the overall worldwide estimated carrier frequency is like a 1 in 200, basically, which leads to a projected worldwide disease prevalence of 1 in sort of 200,000 if you accept sort of Hardy-Weinberg equilibrium and full disease penetrance. So I think that, it may not be as high as this. There's some additional sort of unpublished data which suggests that it probably is like close to as high as this in terms of like FEWA studies that are going on in the States right now. But I think that we probably need to have a higher index of suspicion for DATA2. So the three main phenotypes are this sort of inflammatory phenotype. Patients present with livido, cutaneous ulcers, visceral vasculitis, strokes, and these patients may be sort of diagnosed or misdiagnosed with polyarteritis nodosa, CPAN, Sneddon syndrome. The hematologic phenotype, which is more like there's bone marrow failure, and then also sort of like more autoimmune, sort of hemolytic anemias or autoimmune neutropenia, ITP that can occur. And so patients may present with a more of a hematologic phenotype. And then patients can also present with more of an immunodeficiency phenotype, which may mimic CVID, where they have hypogam, recurrent infections, lymphopenia. And essentially, it has sort of been sort of relatively well established that there's like a genotype phenotype relationship, where patients who have a higher residual ADA2 enzyme activity level are going to present with a more of an inflammatory vasculitis type phenotype, whereas patients with sort of nonsense frame shift mutations that are resulting in sort of basically absent ADA2 enzyme activity level are going to have more of like pure red cell aplasia, bone marrow failure type phenotype. And so I think that, in the hematology clinic, probably patients presenting with more of this sort of hematologic phenotype, they may not actually sort of like be diagnosed until later in life, when they're sort of really getting into trouble with sort of recurrent sort of transfusion dependence, iron overload. We're thinking about sort of like a bone marrow transplant for them. And then sort of as a last check, an exome gets done, and then they end up being diagnosed with DATA2. And so I think that, a high index of suspicion is required for DATA2. And this is just a schematic here, just basically sort of listing sort of all of the manifestations that have been associated with DATA2, really affecting every single organ system. We don't have time to go over it today, but just again to say, like, think about DATA2 in patients who have like weird autoimmunity, one of these phenotypes, bone marrow failure, et cetera, particularly if there's an affected sibling or something like that. And then this is just some unpublished data analyzing the NIH cohort of DATA2 patients, basically just speaking to the fact that most patients in their sort of 60 or so patient cohort had been sort of misdiagnosed or initially diagnosed with a different disease, or sometimes even 2 or 3 different diseases prior to their molecular diagnosis of DATA2. And so some of those things, they've been diagnosed as JIA, systemic onset JIA, PAN, CNS vasculitis, urticarial vasculitis, Behçet's disease, fever of unknown origin, CVID. And so really, like, this is maybe one of those other kind of like great masqueraders that we need to be thinking about a little bit more. And then this is the last slide on DATA2 here. Just basically, they sequenced 100 or so patients with idiopathic polyarteritis nodosa for rare non-synonymous variants in ADA2. And they found basically like a fairly low, but I would still say significant hit rate of about 3.4% that actually had DATA2 associated PAN as opposed to idiopathic PAN. These patients tended to be younger, so in their 20s as opposed to in their 40s, compared to patients with idiopathic PAN. And again, as I told you at the beginning, really TNF inhibitors are what prevents stroke in this population. So really, we should be doing genetic testing for any younger patient who's coming in with a polyarteritis nodosa-like phenotype. So let's talk about the COPA syndrome for a couple of minutes. Has anybody heard of COPA syndrome before? I think in rheumatology, people are starting to look for it. This is an interferonopathy, which was described about like 10 years ago now. There's not been too many patients discovered or reported in the literature, about 80 or so by now, but was probably, again, underdiagnosed. The interesting thing about COPA syndrome is that they can present like ANCA vasculitis, they can present like lupus, they can present like patients with IPAF, right? So idiopathic pulmonary blah, 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 with autoimmune features. So they can have high autoantibody levels, ANA, rheumatoid factor, ANCA. They can have interstitial lung disease. They can have inflammatory arthritis. They can have renal disease that looks a lot like lupus. And there have been rarely individuals with symptomatic onset in their 50s. And again, this is one of those diseases where there's a high degree of phenotypic heterogeneity, where even in families, multi-generational families, people can have sort of different sort of clinical manifestations, even with the same gene mutation. And so really, I'm not going to get into it here, but basically mutations in the COPA gene, my arrow isn't working, but that's okay. So in between STING and STING on the ER and STING in the Golgi, the COPA complex helps to recycle this STING complex, which is important for sort of like viral signaling. And so if you don't have a functional COPA, you basically get sting that's stuck in the signaling position on the Golgi apparatus and sort of constitutive activation of the interferon sort of signaling pathway. And that's what's resulting in the clinical manifestations for these patients. So they may not have fever, they may not have a CRP elevation, they may look more like sort of an autoimmune patient or an ILD patient. But if you do measure an interferon stimulated gene signature, it will be up. And these patients do respond to a certain extent to JAK inhibition or to medications like anifrolumab. And so again, like this is just a list of some of the clinical manifestations of the COPA syndrome. So from pulmonary standpoint, these may be patients who had like recurrent pneumonias in childhood that was actually diffuse alveolar hemorrhage. You may have early onset interstitial lung disease starting before the age of 20. That's actually pretty uncommon. But, if you see somebody like that, you want to be thinking, maybe COPA syndrome, maybe something genetic. They can have, inflammatory arthritis, which may be, mild or maybe deforming. They can have enthesitis, tenosynovitis. They may have renal involvement that mimics lupus nephritis, that may mimic IgA vasculopathy. And the vast majority of them do have positive, strongly positive autoimmune antibodies. And then this is from a review that's a couple years old now, but just drawing your attention to the box here that out of the 60 or so patients that had been reported in the literature at that time, the majority of them didn't have recurrent fevers and the majority of them didn't have, a CRP elevation, right? But nonetheless, it is sort of this innate immune autoinflammatory disorder. And so really just, again, to beat a dead horse, high clinical index of suspicion. These are some of the lung findings that have been associated with COPA syndrome. So classically, the picture of the ILD is somebody who has a lot of cysts that sort of like may mimic like an LIP type pattern of interstitial lung disease with superimposed ground glass infiltration. And then also sort of pronounced septal thickening, which is really kind of like the hallmark features of COPA in terms of the CT findings. And then on biopsy, they tend to have more of like a follicular bronchiolitis histology. And so this is a review that was published by Tiffany Vogel's group last year out of Texas. And they see a lot of these patients. And basically, you should be suspecting COPA syndrome in patients who has at least one pulmonary and two non-pulmonary features, or in a patient who has recurrent alveolar hemorrhage starting early in life. And then you also need to strongly consider testing patients with, a pulmonary feature and then 3 non-pulmonary features. So if you're starting to see this combination of like early onset lung disease, recurrent alveolar hemorrhage, cysts in somebody who has positive autoimmune serology and arthritis, like these are patients that might be like more of like an antisynthetase syndrome, for example, or a Sjogren syndrome, or whatever the case may be. You want to start thinking about sort of maybe sending off some genetic testing for them. And then I don't have time to go over this slide in detail, unfortunately, but just to say that this is, a multi-generational pedigree where the proband actually presented with a picture sort of identical to lupus with nephrotic syndrome were found to have like a proliferative FSGS type picture with full house sort of immune complex disposition consistent with lupus nephritis. And then she also had, I think some, arthritis or lung involvement. And then when you look at the pedigree, actually, like if you take a detailed family history, there's sort of hints going back a couple of generations that there was other people who might have had GN or who might have had ILD. And so in the end, this patient ended up being diagnosed with the COPA syndrome. All right, 10 minutes left here. So 2 more diseases, I think, and then we'll just recap. So HA20, this is an autosomal dominant disorder that was first described in 2016. There's been about 200 patients described to date. Basically, this is a genetic disease that involves upregulation of NF-kappa B type signaling. And it was initially characterized as like a familial form of Behçet's disease, where patients had a lot of sort of bipolar, oral genital ulcers, arthritis, enterocolitis type manifestations, but oftentimes starting sort of earlier in life than a typical Behçet's. It's since been recognized that patients have sort of like a wider sort of phenotype. They may present with recurrent pericarditis. They may present more with like PFAPA, recurrent episodes of fever, oral ulcers, cervical adenitis. They may present with an ALPS type phenotype with lymphoproliferation, lymphadenopathy, massive splenomegaly. They may present with lupus nephritis. They may present with autoimmune hepatitis, vasculitis, etc. And so really, again, this is something where if you have somebody who has like early onset disease or a pedigree that's interesting, where it's sort of like multi-generational, sort of Behçet's or lupus, again, you want to be kind of thinking about sequencing these patients. This is just a diagram for one of the original sort of papers, just showing that patients really do have sort of like these severe aphthous ulcers in the majority of cases. But they can also have, rashes, pathergy, for example, and then also uveitis or retinal vasculitis that can really mimic Behçet's disease. I think we're all pretty comfortable with Behçet's disease, and we probably overdiagnose idiopathic Behçet's, right? So Behçet's Silk Road disease, if you see Behçet's in somebody like of Western European descent or, in North America, like chances are, in sort of Western Europe, chances are it may not be sort of idiopathic HLA-B51 ERAP associated Behçet's disease. It's possible that they may have a monogenic form of Behçet's disease. And so this was Paul Brogan's group in the UK just last year, published a study. There was 31 patients who had clinically suspected Behçet's disease with a median age of onset of 15. Median age of 15 in their cohort ranging from 4 to 50 years of age, median age of onset 0 to 20 years. And out of those patients with early onset Behçet's disease, almost 30% had a monogenic variant that was mimicking Behçet's disease. And so really just to hit it home, like patients who are presenting with early onset Behçet's disease, a positive family history, or atypical presentation, we should be thinking about sequencing those patients. HA20 can also affect the liver. There is a really interesting family down at NIH where actually the proband was discovered to have massive splenomegaly on a school physical exam when he was 13 years old, had already progressed to cirrhosis by that point in time. Biopsies of him and his sister both showed interface hepatitis with positive liver cytosol 1 antibodies infiltrating T cells that was sort of like identical to autoimmune hepatitis, but actually because of this sort of like familial predisposition, they ended up being sequenced, and it wasn't picked up on targeted gene panel. Actually, they had to do the exome, and then they were discovered to have HA20. And these patients are doing actually a little bit better now on JAK inhibition, but just pretty interesting how, this innate immune sort of monogenic disease can present more with like an autoimmune hepatitis phenotype. And then same thing, like HA20 can present as lupus nephritis. And so again, like patients with early onset lupus, familial lupus, these interesting pedigrees, we want to be thinking about it. We don't have time to discuss Rosa syndrome. Really interesting if you guys want to read about it. It's basically a cause of familial blindness that may have additional sort of systemic autoinflammatory manifestations that's sort of like gaining sort of like increased recognition over the last couple of years amongst the ophthalmology community, the autoinflammatory disease community. And they may actually also have some features of like Sjogren's disease as well. This is just some photos of like OCT images showing that there's sort of a lot of sort of optic disc elevation, sort of papilledema, sort of cystoid macular edema, and that actually all of those sort of like changes improve after the patient is treated with tocilizumab, which is an effective targeted therapy for this monogenic disease that involves the NF-kappa B pathway. And then lastly, just with the last 5 minutes here, DOC11 deficiency. So there was 2 papers published last year, one in Blood, one in NEJM. It's an X-linked immune-related actinopathy, small number of patients, but sort of published simultaneously by 2 different groups, one in Austria, one in France. Probably means that, again, this is something that we're missing and we're going to be seeing a lot more of going forward. But basically DOC11, it's a regulator of the actin cytoskeletal dynamics. And so, DOC11 deficiency, there's, abnormal cytoskeletal remodeling, immune dysregulation, and manifestations tends to affect sort of younger men, but can affect older men. Early onset autoimmunity, including cytopenias, lupus-like disease, colitis, skin rashes, cytopenias. And again, this is just like a very busy table. Just basically, I wanted to highlight here the fact that, the French sort of group highlighted more sort of autoimmune manifestations in their cohort, including severe ITP, Evans syndrome, lupus, bullous lupus, high titer antibodies like ANCA, ANA, ENA, thyroid autoantibodies. Whereas the group in Austria, they had more of like a hematologic phenotype with anemia, anisocytosis, hepatosplenomegaly, recurring infections, despite normal sort of immunoglobulins. And so again, like you could argue that maybe this is more of an monogenic autoimmune disease, but it's still sort of affecting, I guess, the innate immune compartment. And so I think the lines between sort of autoimmune, autoinflammatory are increasingly becoming blurred as we're sort of discussing some of these monogenic disorders. Lastly, you know, I spoke earlier about the fact that the vast majority of patients are going to have undifferentiated autoinflammatory disease. You know, at the Kastner lab, they have a cohort of about 3,000 families, but, you know, the minority of them have a molecular diagnosis. And actually, you know, over 2/3 of them are still considered to be undifferentiated despite having had a whole exome or sometimes even a whole genome. And so, you know, some of these patients may have a disease that's waiting to be discovered in terms of a monogenic disease, but a lot of them may have genetically complex disease as well. And so, you know, I hope at the end of this very sort of long and confusing lecture, basically you're not going to remember most of this, but I hope that you'll have an increased index of suspicion for patients who may have an autoinflammatory genetic sort of cause of autoinflammation. They may have cytopenias, they may have autoimmune manifestations, they may have, you know, autoantibodies, they may have lymphoproliferation or immunodeficiency. But really, I think just, you know, those strong sort of pedigrees of sort of familial or early onset atypical immunity should lead you to consider referring on for genetic testing. And I hope that by now I've sort of also sort of like touched a little bit on sort of how these sort of innate immune pathways can help us with sort of like more of a pathway-based management classification that then helps us to choose sort of like more sort of targeted sort of pathway-based management strategies. And so I think that we can, you know, we don't want to throw out the old definition of what is an autoinflammatory disease. I think this is still highly relevant, but we also want to be thinking more in these patients with Behçet's, lupus, autoimmune hepatitis, polyarthritis with ILD and positive autoimmune serologies, early onset stroke, PANS, CVID. We really want to be thinking about genetic causes for these and potentially autoinflammation as well. And that is the end. Thank you so much for your attention. I think I ran out all the time for questions, but if you have questions, you can email me. Yeah, thanks so much again. Thank you.